Welcome, everyone. I'm really excited to be with all of you today, but also to be with Dr. Suzanne Steinbaum. For those of you that do not know, she is a leader in preventative cardiology. She is now in private practice in New York City. And before that, she launched heart disease prevention programs at Mount Sinai, Northwell, Lenox Hill, and Beth Israel. She's CEO and co-founder of Adesso, a technology-based platform prevention model. She also published the book that we are going to be speaking about today, which I realize now is blurred because my background is blurred, but the Heart book, which I have read and I'm excited to dive into. But in addition to that, she has also been a national spokesperson for the American Heart Association's Go Red program for over 18 years. Dr. Steinbaum, thank you so much for joining us today to talk about your book and more.
Thank you. Thank you for having me.
So, can you tell us a little bit about yourself and why you wrote this book?
Sure. I really started the book with the most profound story that happened to me. And it was that I was in my training in the emergency room. And there was one day this 53-year-old woman was wheeled in, and she was clearly very sick, nauseous, sweating. She was holding her stomach and her chest, very uncomfortable. And she was evaluated by the doctors in the emergency room, given the diagnosis of gastroenteritis, or inflammation of the stomach. And she was then put in the corner with that diagnosis of gastroenteritis, and she proceeded to have a heart attack in front of our eyes. It was, that Oprah calls that aha moment. That was really this aha moment for me, where everything sort of slowed down. And I thought, okay, this was not the first time that I had seen this. And this was not the first time that women were sort of treated differently than men and misdiagnosed and not aggressively cared for in these life-saving moments. And I said, that's it. I need to do a fellowship in women and heart disease. And I went to the chief of cardiology and asked him for that. And guess what he said?
Doesn't
There's
exist.
no such thing. And so I really thought about it and thought, well, if we prevent heart disease in women, then they won't get as sick. So I want to do a preventive cardiology fellowship. And I asked him if I could do that. And guess what he said?
No.
There was no such thing. But I happened to be in the right place at the right time. And he went out of his way and got a preventive cardiology fellowship, CGME, approved for me. And I was one of the first cardiology fellows in the country. And that was 20 plus years ago.
That's amazing. That's amazing. And, it has been some time since you wrote this book in 2013. And I know we were chatting before we started the webinar about how you can't believe that time has gone so fast. And it seems like time goes faster and faster every day. But looking back, like 11 years now, what in preventative cardiology and specifically related to women has changed and what has stayed the same?
I think what really started then, and we have to really remember something, there was no research done on women's hearts till 1993. It takes about 20 years for research to hit clinical practice. And when I wrote this book, it felt like the time was then, that this is when we really needed to make the shift and understand women's hearts, because we started really getting the data around how women's hearts were a little different, that there was endothelial dysfunction or a problem with the lining of the artery, that the small arteries were affected versus the large arteries in men. And so we started understanding that women's hearts were different than men's hearts. And when I wrote this book, I felt like it was that moment that women needed to understand it, not just doctors, because the women needed to start advocating for themselves. So now we are, as you reminded me before we got on, 11 years later. And what has changed is not much. We're pretty much in the same place, although I would like to believe that the message is out there more, the need is out there more in understanding We have terms for these things now that we didn't have back then. We know what to call heart attacks in women when there are no blockages in the arteries. And back then we called it syndrome X. Now we know what to call it.
Right.
We know what to call it when a woman doesn't quite have a heart attack, but she's having symptoms of similar to blockages in the arteries where there's chest pain or shortness of breath, but we know that there's no blockages, that it's due to the small arteries, the microvasculature. We have a name for it. The heart attack one is called Minoca. The one without a heart attack but ischemia, this chest discomfort, is called Inoca. I mean, but we understand the mechanisms a little better. We understand the diagnosis a little better, but what I wrote 11 years ago is no different. It's really about perfecting the science, perfecting the research, but the reality is still the same. And what I would like to say is that we have to focus now more on the nuances of heart disease in women, the equity of care, the access to care, because what we're seeing is more women die of heart disease more than all cancers combined. We are seeing our population age, and women spend 40% of their lives in menopause. 70% of those women will have some form of heart disease. So we're addressing a bigger population, a greater amount of women. We're understanding the true impact of preeclampsia and gestational diabetes, multiple miscarriages on heart disease that can occur within 5 to 10 years in young women. And lastly, we're seeing a rise in heart attacks and strokes in women less than 55 years old. So if we don't do something now on a bigger scale, in a bigger way to empower women and the doctors, I think we're missing the moment. And let's face it, COVID didn't help us. That really increased the risk of heart disease for all people, but certainly has had an impact on women's hearts in a way that we're still seeing the effect of.
You talk a lot in your book about heart throbs. Can you tell us a little bit more about what those are and what we should know about them?
I want to start by saying the one phrase that I keep reminding everyone now is heart care is the new self-care. And part of that is because of these heart throbs. Heart throbs are all the things that actually increase stress in your life. It's the things that trigger your sympathetic nervous system, that fight or flight nervous system. So we think of risk factors like high blood pressure and high cholesterol and elevated sugars and smoking and lack of sleep and stress, bad diet, sedentary lifestyle. Those are the risk factors. The heart throbs are all the other things that trigger your stress. So it's the beeping sound outside of my window of a truck going back, or the ambulance that's going on nonstop, or sitting in traffic, or not getting a call back from someone, all of the things that raise our stress hormones. So the heart throbs, I think, are really unique to you, but it's really the things that we have to pay attention to that bother us, that trigger our fight or flight.
You just mentioned, stress. And I know in the book you talk about stress and depression and anxiety and how women experience those differently and they have different impacts on their heart. I know I feel stress and anxiety all the time. How is that impacting my heart on the day to day?
A woman with depression, stress, there is a twofold increased risk of cardiovascular disease compared to men. So these psychosocial things, I'm going to call them, the anxiety, the stress, loneliness, depression, job problems, dissatisfaction, or stress at work, all of these things actually really do have an impact on our risk of heart disease. So one of the things that we need to understand is that how we think and how we feel has a direct impact on our hearts. There was a really interesting study in 1994 that showed there are cells on the heart that are same as the cells of the brain. So those stress hormones hit our hearts directly and increase our heart rates, our blood pressure, clamp down our arteries, increase inflammation, and it goes right to the heart. It's not like it comes to the brain and circulates in our body and releases adrenaline. It goes right there to create these problems. So how we think and how we feel has that direct impact. If we can change how we approach things, our perspectives, how we manage to look at things, we can actually have an improvement on our heart health.
Well, I'm going to start working on that one today because
Good.
it's crazy. But let's now shift to sort of the second part of your book where you actually give women tools and highlight for them what they really need to be focused on. And two of the areas that you have chapters on are diet and stress, or sorry, diet and exercise. Sorry. So, starting with diet, what are some of the things that we have to keep in mind as we are consuming food on a daily basis? And, you share some of your practices and dietary rules for life in the book. Do those still stand 11 years later?
There's one of them that makes me laugh. I know the no carbs after 3 rule, I think, was
Yeah.
one I wrote. I I think that we have to have a really big picture understanding of the impact of food on our health. And we certainly know the effects of chemicals and things that we cannot control. There's so much out there now about plastics in our food and things like that. And I'm going to put those aside. And I didn't address them in my book because this is about what you can control. And when you look at what you can control, the best diet, and I believe the same now, is the Mediterranean diet. It has been shown across the board to be the most heart healthy and really prevent all kinds of diseases. And that Mediterranean diet is filled with vegetables and grains. That's a carbohydrate. So you're allowed to have a carbohydrate after 3 as long as it's a multigrain and high in protein, the ancient grains. But things like nuts and olive oils and fruits that are low in sugar and low fat. And I'm not someone who really professes to have high fat foods like meat, turkey, chicken. I don't think that's part of a heart healthy diet. There has been so much talk about paleo and keto and all of that. I do not believe that to be the best heart healthy way to eat. That really it's about fish, omega 3s, healthy fats are essential, but really having this multi-grain, multi-vegetable and omega-3 diet is really the best way to eat.
And then for exercise, I think and I speak for myself and many of the women in my life, since the pandemic, our diet has been a little bit off because there is a lot more stress, a lot of stress eating. Our exercise has been a little off too. We've been more sedentary, sitting more, not, if we're working from home, we're not doing the things that we normally did in our day to day lives as we commute to the office, walk back and forth down hallways. So, what are some pieces of advice you have around exercise in 2024 and how we fit things in?
I stopped talking about exercise and started talking about movement
Mm.
and how important intentional movement is. And let's call intentional movement exercise and daily movement, getting up, walking around, making sure you're not staying seated. The one great thing about working from home for many of us is you have more choices. And those choices are I get to stand up and run in place every hour on the hour before I hop on another Zoom call, or I get to take a walk around the block in between meetings. And I think having those daily movements in your life are really important. There was a time people were sitting in a car, commuting for an hour, getting to work and sitting at a desk all day. Well, now we sort of can change that narrative and make choices about getting up and moving all day. And now we get to say 30 minutes of moderate intensity exercise, which means we don't have to kill ourselves in the gym, but we just have to get our heart rates up to this moderate intensity point where it's a little difficult speaking, but you can sort of finish your sentence. That's where you need to exercise in a sweet spot. And in doing that, along with those daily moves, 5 days a week, that's really all we need for cardiovascular health. And I think at one point it was about going to the gym and killing yourself and kickboxing and step class and just so much of that real high intensity exercise. We don't need that for cardiovascular health. We need that moderate intensity along with those movements and 2 times a week of some strength training. So we really can keep our muscles fit and our bones healthy to prevent osteopenia and osteoporosis. And all of this improves our mood and helps us sleep, keeps those arteries healthy and dilated. And I say it in the book, for me, exercise is the best medication.
Absolutely. And I love how you shared in the book that, your son did it right along with you, right? And then before our call today, you said he's going to be a college athlete, which is
Yes.
great because those activities were sort of ingrained in him in a young age. And I think that's something that we can do for future generations as well as we're working to improve our own heart health. For those of you that are on the line, feel free to put your questions in either the chat box or the Q&A, and we'll turn to those very quickly. But before we do, Dr. Steinbaum, I just want to give you a chance to talk a little bit about what you're working on now, post book, what you're seeing with your patients, what you're trying to address with my Adesso. Would just love to hear all of that for the future.
The one thing that became very clear to me in this journey is that in order for us to get women's care altered, we have to go to where women get care. And women are not going to cardiologists unless they're sick and referred, but most women are going to OBGYNs or to primary care doctors. And so Adesso is focused on primary care doctors and women. So testing can be done within their offices to create preventive strategies with diet and exercise and also stress management supplements. But we're also focused on My Adesso, which is a platform which I'm so excited. Any minute now is going to be in the Apple Store. It took several years to build. So this is like birthing the book. It's birthing the next thing. But My Adesso is really about self-empowerment and understanding who you are. And it starts with what we call the heart score for you to understand your own personal risk from not only your family, but your life, how you think and how you feel, where you are hormonally. It really incorporates the entire you to create an educational journey for you to understand more about yourself, more about your heart. And it tracks. It helps you track. What do I want to change? What do I want to do better? Whether it's diet, exercise. We talk about relationships and how important they are. And that's something that we help you with. Did you call someone today? Did you make time for yourself? And it's not only to address those issues and journal it every day, but it also syncs to your ring and to your watch and allows you to track those lifestyle choices.
That's great. I'm so excited to have it be in the App Store and have people be able to take advantage of it. It sounds really exciting, and it sounds like it highlights for us a lot of things that we may not realize are connected to our heart health, right? Like we may not realize those things that are happening around us are actually, impacting what happens to our heart in the future. We do have some questions that have come in. So I'll start with the first one, which is, can you comment on HFPEF in women? Is it more prevalent in women, and what can we do about it? And I'm actually not familiar with HFPEF, so if you could share what that is.
Sure. So it is heart failure with preserved ejection fraction. And what that means is when women or when people have a heart attack, they usually lose heart muscle. And so the heart doesn't pump as well. And that's what we traditionally think of with heart failure. What this question about is more common in women. It means that the heart muscle is not actually destroyed. It's actually pumping very well, but the heart isn't relaxing as well. And the pressure, because there's lack of relaxation, goes back into the lungs where fluid fills into the lungs. And it's a form of heart failure that happens more commonly and more often in women. And one of the reasons that I wanted to be a preventive cardiologist was that if we focused on controlling the blood pressure and really managing microvascular disease, which is the primary problem of women and the primary driver behind heart failure with preserved ejection fraction, that we can actually prevent the most common thing that happens in heart failure, which is devastating in women. And it is my goal that through our program that we can actually do that and get there. And it was a really smart question. Thank you for asking it, because it's really relevant to women's hearts and one that we're really working on.
Wonderful. Well, thank you for answering that and sharing what that is for all of us. We have another one. What happens to women's hearts when they are pregnant with things like gestational diabetes, high blood pressure, etc.? What do women not know about this that they should?
When women have adverse outcomes of pregnancy, like preeclampsia or gestational diabetes, what we're calling it is it's the first stress test for the heart. Pregnancy is your first stress test. And when something like preeclampsia or gestational diabetes happens, we're saying there is a problem actually with the arteries dilating. There's such an increase in blood flow that needs to happen in a woman's body to support the growing baby, that when those arteries are not dilating as well, that's when complications happen. Placenta previa, multiple miscarriages, early delivery, small birth weight are included in this. And we see in these women in 5 to 10 years, they have some effect of it, whether it is diabetes, whether it is high blood pressure, and elevated calcium scores, which is associated with plaque in the artery, we will see in these women. So when we used to talk about heart disease all that 11 years ago, um, so many times it was this older woman's disease, but it's not, because we're seeing it happen in younger and younger women.
Yeah, and I'm so thankful you shared that and that we got that question, because a lot of times when I'm in conversations with hospital leaders, there isn't that connection being made to pregnancy as a stress test for the future, right? And how it connects to cardiovascular health for women in the future. And I see a real gap even in how clinicians are asking questions and evaluating women post pregnancy, right? Even asking the question, have you been pregnant in the past year? Have you
Right.
had a pregnancy? Have you had children? Because I think all of it is really relevant, and it's good to see that conversation starting to happen, and eventually that it will change. We do have one more question, and it is a bit about an individual's medical condition, but you can answer it sort of generally. But what are your thoughts on the contraindication of fertility drugs on statins? My cardiologist did not recommend being put on a statin despite high cholesterol because of my IVF hormone therapy.
I think it's more about the pregnancy piece than the IVF piece. We tend to take patients off of statins when they're pregnant, and oftentimes cholesterol will go up during that time. We wait until after pregnancy and things settle hormonally to restart statins. And that's been how we've approached it. The one interesting thing I want to mention about that, and this is a perfect example of how things have changed years ago, and this is before my time, actually, obstetricians did not treat high blood pressure unless it got to preeclampsia. But women that had chronic high blood pressure oftentimes did not get medication during pregnancy. And a lot of times the pregnancy will come down, sometimes it doesn't, but they would not prescribe medication. And now we know that women with chronically elevated blood pressure should be treated during pregnancy. That very small, simple thing is huge, and it changes outcomes. And as the guidelines change and the research changes, there's a perfect example of that. But where we are right now from the statins is we pull it back, we wait till the baby to come, and then we restart. I think every woman is individual. I think part of why my Adesso was built is for every woman to understand her own personal journey. We do talk about pregnancy in my Adesso because every woman's situation is different. And what becomes important and what your question really reveals is how much we need to kind of research on our own so we can come to our doctors and ask the right question. Is the answer, my cardiologist doesn't want to do this and that's it? Or is it, my cardiologist doesn't want to do this for this patient, but I'm like this and I'm different from that patient because of this? We all don't fit into the box of the research protocols. And so we really need to come forward with our own self-education and with our own information to get the answers that we need for our own individual situation. That's part of what Adesso is about. And that's what I really recommend for all of you to do.
Yeah, that's great advice. We have one last question, which we'll try to get to in our 3 minutes that we have remaining. But are there ways to reduce heart failure once it occurs, or are you stuck with it once hypertension advances to congestive heart failure?
So it depends if you have the decreased ejection fraction type or the preserved type. It's all about treating those risk factors, getting the blood pressure down. Actually, exercise is so critical to both. For heart failure with a decreased ejection fraction, there's medications out there now that are so powerful that we did not have that have improved heart function. And with that preserved ejection fraction, I will tell you, it is so much about getting the risk factors, the blood pressure down, the sugar down, really getting the cholesterol low. And the power of exercise in that situation should not be underestimated.
Great. So I just want to end with one last question for you. In your book, you share some of the responses you get from women when you talk about the importance of heart health. Everything from I was born this way to I'm big boned to heart disease is in my family, so I'm going to get it no matter what. But you also share that 80 to 90% of heart disease cases are preventable. So if you had to leave this group of women with one piece of advice or one thing that they should start doing immediately following this discussion, what would it be?
The most important thing I will tell all women, and I think I wrote this in the beginning of the book. I wrote this book because this is the book I wish someone gave to me when I was in my 20s. The earlier you start, the better off you are, regardless of your history, regardless of your family history or how big boned you are or any of it. The earlier you start, the more that you can prevent heart disease. It takes decades and decades for it to develop. And if we could understand early in life how to eat the healthiest we can for us, how to move in a way that really takes care of us, how to sleep properly before we reach menopause, when sleep becomes an issue, when everything gets harder. If we set up ourselves for success when we reach midlife and we're in perimenopause and menopause, we will actually be able to prevent heart disease for all women. And so what I'm going to tell you is find out who you are, understand what your risk factors are, what your heart throbs are, what triggers you, what you need to stay as healthy as you can be. And once you understand that, as I say in my book, live from that place, live from the heart, live from that place where you can be as healthy, as heart healthy as you can. And that includes living with passion, living with purpose, being optimistic, half glass full, changing those thoughts like we talked about from really being anxious and nervous to I've got this, because all of this really does matter. And my parting word is empower yourself with education and knowledge, become your own advocate, and you can actually live a really vital and healthy life for as long as you want.
Well, I think that is the perfect place to end today. Dr. Steinbaum, thank you so much for being with us, for writing this book, and for all that you're doing in the field of cardiology to help women understand their risks and how they can help mitigate them for the future. And I'll just restate your advice from earlier in our conversation for everyone to remember as they go about their days. Heart care is the new self care. So I hope this discussion was helpful to all that attended. And thank you for making time for yourself and your heart this afternoon. And thank you again to everyone. And we'll talk soon.
Thanks, Priya.